Bismillahirrahmanirrahim. My name is Dr. Khalid and my moderator is Dr. Riaz Lagari. Today's my topic is anastomotic urethroplasty, flaps and graft for urethral reconstruction and augmentation urethroplasty. Introduction: urethral structure refer to interior urethral disease or scarring process involving the spongy erectile tissue of corpus spongiosum. Posterior urethral structure are not included in an obliterative process in the posterior urethra that has resulted in the fibrosis that effect of destruction caused by the trauma or radical prostatectomy. This is the basically blood supply of there are two basically blood supply, proximal and distal. The genital skin has dual blood supply, proximal and distal, bilateral blood supply forming a fasciocutaneous system. Corpus spongiosum receive blood from the common penile artery and the terminal branch of internal putational artery. The corpus spongiosum also have dual blood supply, a proximal blood supply and retrograde blood supply through the dorsal artery as they arborize in the glans penis. This is the picture.
I think this blood supply is very important. Usman will tell us about this blood supply. Why we'll not do the EPA urethroplasty in hypospadias patient?
I think the patients who have hypospadias has already compromised blood supply to the urethra. So if we do EPA, if we see that picture, the internal putational artery gives two branches that give the bulbar artery and the dorsal arteries. In hypospadias, we have compromised the dorsal arteries. So if we transect the urethra, bulbar arteries are also compromised. So there is less chance of healing and more chance of free stricture formation.
Quite right. Okay, continue.
This is the picture showing this is the short structure, and this is spongiofibrosis, extensive spongiofibrosis if within 2 centimeters, greater than 2 centimeters is substitution. Types of interior urethroplasty. Anastomotic urethroplasty. Structure less than 2 centimeter, bulbar urethra relies on the mobilization of corpus spongiosum. Results behaving excised complete structure, speculated anastomosis, overlapping ends, outcome long-term success over 90 to 95%. This is a picture showing, this is the structure urethra, and this is the excise and anastomosis. Complication: ejectionary dysfunction 20%, decreased gland sensitivity 18%, poor glands erection 11%, cold glands 1.6%. Vessel sparing excision with primary anastomosis. Dissection of the space between the proximal vascularity and the membranous urethra. The artery to the pulp is preserved. The area of the proximal structure can be excised. The membranous urethra is speculated at the dorsum, has its proximal bulbous urethra. Substitution.
So this is non-transecting urethroplasty. It's a slide. This is non-transecting urethroplasty. This is EPA, and next slide. This is non-transecting urethroplasty, in which we will not transect the urethra. We only incise the dorsal surface of the urethra and then we anastomose the urethra. So the continuity of the blood supply is continued, and there is no erectile dysfunction as you depicted in the next slide. Aage aao. Or piche. This. So erectile dysfunction can be prevented or minimized by doing the non-transecting urethroplasty. But non-transecting urethroplasty can be done up to 1.5 centimeter stricture. We cannot do non-transecting urethroplasty more than 1.5 centimeter. If we have a more than 1.5 centimeter stricture in the bulbar and the penile urethra, so we have to do, if we want to prevent the erectile function, then we have to do the substitution urethroplasty, either ventral onlay, lateral onlay, and dorsal onlay urethroplasty, VMG urethroplasty.
Substitution urethroplasty. Introduction. The use of graft and flap play a critical role in the successful surgical management of urethral disease. Introduction. Graft refers to tissue removed from its donor site without its native blood supply and relies on the establishing new circulation through a process termed take. While the flap is a unit of tissue that is transferred from one side, donor side, to another site, that is recipient side, while maintaining its own blood supply. Types of graft, basically three types of grafts.
What is take, Furkani? And what are the two steps of take?
Take is the process through which the closed graft establishes blood supply at the donor site,
Mhm.
and
What are two steps of
imbibation and the other is inoculation.
first 48 hours में कौन सा होता है?
Imbibation होती है, then next
What do you mean by inoculation?
inoculation means that the graft at donor site start to establish its blood supply from the
Yes, there is a formation of blood supply in the graft from the donor side. कुछ कहना चाहते हो?
Types of graft: spread thickness skin graft, full thickness skin graft, composite graft. Splint thickness graft, composed of epidermis and superficial part of dermis, indicated for a large wound, can survive on relatively avascular site where the full thickness skin graft would typically fail. Full thickness skin graft, containing the both full epidermis and dermis, indicated for a small avascular area less than 1 centimeter or for the larger area with a good blood supply. Large graft over a bone and cartilage without any intervening tissue are prone to failure. Composite graft, containing skin and other type of tissue, usually cartilage, indicated in the situation where a donor site has lost underlying muscle or bone. The most common composite graft is dermatological surgery or graft containing cartilage used to reinforce the nose or ear. Advantage and disadvantages of graft. Thin split thickness, best survival, heals repeatedly, while disadvantages: least resembling original skin, least resembling to trauma, poor sensation, maximal secondary contraction. Thick split thickness, more equalities of normal skin, less contraction, looks better, fair sensation, while disadvantage is the lower graft survival, slower in healing. Full thickness graft, most resembling normal skin, minimal secondary contraction, resistant to trauma, good sensation, aesthetically pleasing. While disadvantages are poor survival, donor site must be closed surgically, donor sites are limited. Rationale for the graft and flap in the urethral reconstruction. Severe variants of hypospadias, severe complication of hypospadias repair, urethral strictures, cordy without hypospadias, epispadias, and urethral loss from trauma. Process of graft take. Basically 4 steps. Fibrin adhesion that takes place immediately. Plasmatic imbibition is the nutrient absorption from the host bed within 48 hours. Inoculation will take place from 48 to 96 hours after the graft, or last is the revascularization. Condition for the graft success: well vascularized host bed, immobilization of the graft, complete contact of the graft and the bed, rapid onset of imbibition, that is the passive diffusion of nutrient from the host bed, rapid onset of the inoculation in a growth of the blood vessel. Factors that affect the graft take is maybe local or systematic factors. Oxygen, if oxygen supply is decreased, then they affect the graft. Blood supply, residual infection, if there is any residual infection, foreign bodies, repeated trauma or radiation. Systematic diabetes, nutritional status, jaundice, uremia, drugs, shocks, hypoxic state, genetic disorder, arterial disease. Factors that predispose to the graft failure: a poor wound bed, shear, hematoma, seroma, pus, infection. Grafts, these are the graft. Buccal mucosal graft, posterior auricular skin, this is called Wolfe, lingual and labial, rectal mucosa, or bladder epithelium.
So the best grafts are buccal mucosal graft. Why? Kosher. Kosher hai? In comparison to these grafts, the base graft for urethroplasty is buccal mucosal graft. Why?
I don't know.
Jamal will answer this question.
Sir, first thing is that donor side healing is very good, and you can take the graft as much as you want. More than 6 centimeter graft can be used. And at the
How much graft we can take from the buccal
more
mucosa?
than 6, total about 16
16
centimeter
centimeter.
of
Okay.
the graft.
Okay.
And where are you putting the graft? It has a good angiogenesis over there.
And Kamal?
Also when we're using to the urethra prone that urine can pass from there, and easy to uptake. And one thing is mentioned that donor side can be taken up to the 16 and easy heal to the donor side, no less complication around the donor side.
So what is the most common complication you will see in buccal mucosal grafting harvesting? And least common? कौन सी होती हैं?
Bleeding would be contracture formation, fibrosis.
And least common? और कोई duct injury होती है? Stensen's duct injury. Okay.
Buccal mucosal graft urethroplasty. In 1993, first time the ex-Kebze et al. Reported that buccal mucosal graft from the lower lip was used for treatment of penile and bulbal urethral stricture in adult patient without hypospadias. Buccal mucosal graft. It is easy to harvest. It is tough and resilient, easy to handle. There is usually enough for it. It takes well a thick epithelium and a thin dermis with a dense subdermal vascular plexus. Allow early inoculation. BMG. There is an acceptable morbidity at the donor side. It is customized to being wet. It is resistant to certain skin disease, resistant to infection, prevalent allergy. This is penile one-stage dorsal inlay buccal mucosal graft. In this basically dorsal only graft. The buccal mucosal graft is applied on the corpus cavernosa and converted by the urethra, covered by the urethral mucosal plate and by intact spongiosum. This is buccal mucosal graft. This is applied. Penile one-stage dorsal only buccal mucosal graft. This Kulkarni-Berberi method. Basically, in this method, the urethra is completely mobilized dorsally. The graft mucosa is applied. This is the urethra that is completely mobilized.
Basically, urethra is mobilized completely, and we have to give the incision at the stricture site on dorsal surface, and then we have to apply the graft on the dorsal aspect at corpus cavernosum, and then we attach the urethra with the graft. So this is dorsal only BMG urethroplasty. If we do the in the bulbar urethra, it is called Barbegley urethroplasty.
This is a ventral only buccal mucosal graft urethroplasty. Ventral only, the buccal mucosal graft is applied on the urethral mucosal plate and spongiosum tissue is covered over the graft. Post auricular graft.
Ventral only कैसे लगाएंगे? किसी को पता है? देखा है किसी ने? अरसलान, कमल ने देखा होगा. कैसे लगाते हैं? कैसे ओपन करते हैं? So in ventral only BMG urethroplasty, we should not mobilize the urethra as much, and we have to expose the urethra, and then we have to give the incision on the ventral side. The side which is in front is facing the surgeon is called ventral surface of urethra. So we have to give the incision at the ventral surface, and then we put the graft, and then we close the graft. We have to close the corpus spongiosum over the graft. So why we have to close the corpus spongiosum over the graft? कौन बताएगा? रेजिडेंट भाई वेंट्रल ऑनले में हम क्यों सपोर्ट दे रहे हैं?
Provide wet for the graft uptake and provide the blood supply and also provide a support to the graft
To prevent the
prevent the diverticulum.
future diverticulum. Yes. Usman कुछ बता.
Dr. Khalid, can you go back to the previous slide? I want to add few words regarding the Kulkarni or Barbecue technique.
Yes.
In true or classic Barbecue technique, there is complete mobilization of urethra on both aspects, circumferential mobilization. While in Kulkarni, there is only one-sided mobilization, and one side is preserved so that on one side the neurovascular bundle is intact and there is less. There's a good blood supply or more chance of healing in that.
Basically, Kulkarni technique is described that we have to mobilize on one side and we have to place a graft on lateral side. This is basically lateral onlay BMG urethroplasty. This is not purely dorsal or dorsolateral BMG urethroplasty, not purely dorsal BMG urethroplasty. समझ आया कुछ या नहीं?
Post-auricular graft Wolfe. The limits of the graft size that can be harvested is roughly 2 into 5 centimeter, and the other is the lingual mucosal graft. Preputial skin
तो
graft.
lingual mucosal graft कब यूज करेंगे? कौन बताएगा? बक्कल म्यूकोजल नहीं होगा जब भी यूज करेंगे क्योंकि हमारे जो है वो पॉपुलेशन में पान चीविंग बहुत ज्यादा है, तो जिसकी वजह से बक्कल म्यूकोजल सब म्यूकोजल फाइब्रोसिस हो जाती है, तो जिसकी वजह से बक्कल म्यूकोजल सारा जो है वो खराब हुआ होता है, लेकिन फॉर्चुनेटली लिंगुअल म्यूकोजा बचा हुआ होता है, तो हम उसमें से लिंगुअल म्यूकोजल ग्राफ्ट ले सकते हैं. ठीक है.
Preputial skin graft. It's a thin, pliable, diverted of air proximity to the urethra. It's thinning procedure which is required for the harvest of other donor site. It's not required. Preputial skin graft do not need donor site care. Donor site is hidden. Do not cause scar. However, can be affected by lichen sclerosis, which makes it unsuitable for use in the urethral reconstruction. Now, overviews of flap. The flap is a unit of tissue that is transferred from one side, donor side, to another side, that is recipient, while maintaining its own blood supply. Classification of the flaps. The flaps can be classified in different ways, each depending on the particular characteristic of the flap, based on the blood supply, that is axial, island or peninsula, and random pattern flap, based on the types of tissue, that is fasciocutaneous and myocutaneous, based on the location of donor site, local, regional, or distended, based on the technique of movement, this is rational, Z-plasty, or advancement. This is the picture. Peninsula, island flap, and microvascular flap. This picture showing this is attached. This is free from three sides, attached with source and blood supply. This is peninsula. This is also, this is free from source, blood supply is attached and free from all sides. And the microvascular free flap, that's not attached with source, blood supply is intact and free from all sides. Sources of the flap for urethral reconstruction: dortus flap, penile skin flap, dorsal scrotal skin flap, tunica vaginalis. Factors that predispose to the flap failure: tension, kinking, compression, vascular thrombosis, and infection. Factor that influences the choice of treatment: site of urethra affected, length of urethra, number or etiology, nature of the genital skin like BXO, lichen sclerosis, comorbidities like oral mucosal lesion, presence of complication like fistula, surgeon expertise, and fluoroscopy. Ideal substitution tissue: moisture resistant, hairless, in plentiful supply, easy to harvest, leaving no scar, easy to handle, Little shrinkage, easily take on the recipient side, have its own blood supply, resistant to the infection. Augmented anastomotic urethroplasty. The augmented anastomotic urethroplasty is a combination repair that incorporates the principle of excision substitution urethroplasty and is primarily used for those bulbar structure deemed too long for a straightforward primary anastomosis. In this repair, up to 2 centimeters of affiliated urethra is excised and the ventral urethra is reapproximated and buccal mucosal graft is applied dorsally. The augmenting the anastomosis and addressing any adjoint wide caliber structure. This is a longitudinal ventral penile skin flap with a lateral pedicle technique. Basically, this technique of Orandi. In this longitudinally flap is raised with their lateral pedicle. This is a longitudinal ventral penile skin flap with a ventral pedicle technique of Turner-Warwick. In this longitudinal ventral penile skin flap is taken with their ventral pedicle, while in the Orandi pedicle is taken laterally. This transverse circular skin flap with a primary dorsal pedicle technique of McKenkie. This circular penile skin flap. This is Q flap. Basically, it's look like Q. Otherwise, combined tissue transfer. This combination skin flap and buccal mucosal graft. It's appear that the success rate of at least the Orandi and McKenkie flaps likely that the Turner-Warwick flap as well as similarly 5% failure at the 1 year, 20% at the 3 to 5 years. Results are better with the Onlay flap, 10 to 50% failure long term. Then the tubulization flap, 30 to 60% failure long term. Flap can be ventral, longitudinal, Orandi for the pendulous urethra, ventral transverse, that is Jordan or Devine, for fossa structure, or transverse circumferentially, this is a Quattari and McKenkie or Q-type for interior urethra. Bilateral buccal mucosal graft harvest from the cheeks typically will give graft of 6 cm depending on the oral anatomy. This can be used to repair the structure up to 12 cm in the cases of peniurethral structure. Another option for the reconstruction the peniurethral structure is the Q flap. The Q flap is a modification of a circular penile fasciocutaneous skin flap. Procedure is called McKenkie flap. Scrotal flap urethroplasty. Basically, the patient is placed in a lithotomy position. The flap of scrotal skin is dissected, free it from base interior to the anus. And the urethra is this is urethra. Bulbar muscles are retracted. Flap is raised. This is the structure, urethra, and this is the bulbar junction. Open posterior wall. So, scrotal flap suture in a position, interior urethra, and this is the flap. Posterior structure, PFUDD.
Now question arises that why a buccal mucosal graft is preferred over the penile skin graft? Who will answer this question? Arsalan? क्या कॉम्प्लिकेशन हो जाती हैं पेनाइल स्किन ग्राफ्ट या फ्लैप लगाने के बाद, इसलिए हम फिनाइल स्किन फ्लैप यूजुअली यूज नहीं करते.
सर बक्कल मुकोसल ग्राफ्ट आर डिवाइड ऑफ हेयर और पेनाइल स्किन ग्राफ्ट में हेयर.
Yes, there is a development of hair later on after 2 to 3 years.
It may cause obstruction, or
it may cause obstruction, may cause infection, may cause graft loss or flap loss. So that's why penile skin is not used in fashion right now.
Posterior urethral structure, PFUDD. The general principles of the urethroplasty for the posterior urethral structures were worked out many years ago. Those principles are that it is almost always possible to define that healthy urethra above and below the site of the injury of surrounding fibrosis and perform a speculated end-to-end anastomosis. Indeed, substitution urethroplasty should never be performed except in a very exceptional circumstance, usually as the consequence of previous surgery or negligence. Second, it is almost always necessary to reduce the tension of anastomosis to reduce the risk of recurrent stricturing. While mobilization of the urethra alone is insufficient to reduce the tension of anastomosis, tension can further reduce by the straightening out the natural curved course of the bulbar urethra from the pinoscrotal junction to the apex of the prostate. This curve may be as much as half of the 5/8 of the circle, and the curve is produced by the fusion of the corpora cavernosa over the inferior aspect of pubic symphysis. Thus, the urethra can be straightened out by separating the cura of the penis as far as this is possible by performing a wedge resection of inferior pubic arch. Unfortunately, the degree to which the cura can be separated is variable. It may not be possible to completely straighten out the urethra by cural separation alone, in which the case the urethra must be rerouted in some patient around the shaft of the penis rather than between the two corpora. This sequence of the mobilization process to the cural separation, which necessary proceeding to inferior wedge pubectomy when necessary, proceeding ultimately to rerouting of the urethra around the shaft of the penis when necessary, is known as transperineal process approach, first time referred by Webster. Occasionally, the proximal urinary tract, the bladder, and the prostatic urethra is displaced interiorly rather than posterior and stuck on the back of the pubis is inaccessible from below. Occasionally, there is a bladder neck injury or simultaneously rectal injury or the false passage. These all require an abdominoperineal approach rather than a purely perineal approach. There is a more common in the children in whom the corpus spongiosum is less well developed and therefore there is a less elastic. Approaches. Perineal approaches: bulbar urethral mobilization, cural separation, elaborated perineal is Webster. Inferior pubectomy, supracural rerouting of urethra, or perino-abdominal approach, this is called Turner-Warwick, total pubectomy or omental wrap. These are the steps basically. The bulbar urethra is mobilized, cural separation is new, inferior pubectomy, supracural rerouting, fourth one. Fifth, total pubectomy, after pubectomy, mental wrapping. It's abdominoperineal approach, pubectomy, and primary anastomosis. Bulbar prostatic gap, bulbar urethral length, less than 1/3, less chances of pubectomy. Less than 1/3, less chances of pubectomy. More than 1/3, more chances of pubectomy. This is the picture showing a simple structure. That is the we can approach perineal approach. Simple structure plus retropubic fibrosis. This synchronously perineal or retropubic approach. Complex structure, long plus fistula plus bladder neck incompetency. The synchronously perineal transpubic approach. This is the perineal anastomosis. Perineal anastomosis with omental support, or partial transpubic anastomosis with omental support. This is the total transpubic anastomosis, supracus urethral rerouting with omental support. Stage urethroplasty.
Professor Murli is there. So do you have an experience of total pubectomy here, or you have seen a case of total pubectomy in PFUDD stricture?
I don't have an experience. Even I haven't done pubectomies in my whole experience of urethral stricture surgery. So, but I have seen people doing this, but partial pubectomy is preferred. Total pubectomy is not preferred. Then you go for rerouting and do other maneuvers to
Gain the length of
the urethra.
I want to add on it. The concept of total pubectomy is more or less abundant now because of its complication. Because in patients in which the total pubectomy was done, there was waddling gait, there was more chance of pain, and the success rate was not that much beneficial in which we do the inferior pubectomy or the total pubectomy. So due to its complications, it's more or less abundant nowadays.
Stage urethroplasty. Stage urethroplasty is an important element in the armamentarium of the urethral reconstruction surgeon. While the vast majority of urethral injury and strictures may be addressed with a single stage reconstructive techniques, there are various situations in which a stage approach may be preferred or essential. The underlying disease process, the condition of a local tissue, or the history of the period surgical intervention may create a situation in which a single stage procedure is ill advanced. The presence of local infection or inflammation, or the problem of an obliterative urethral segment with an in-hospital graft bed is necessary to temporary creation of the proximal urethrostomy while replacing or augmentation of the structure urethral segment. Previously, penile skin mobilization from the perineal flap or the hypospadias procedure may prevent repeat single stage flap procedure requiring a stage approaches. At the conclusion of the first stage, the patient would avoid through a urethrostomy at some level, penile shaft, scrotal, or perineal. A period of approximately 3 to 6 months to 1 year or more given before the second stage procedure. This is Turner-Warwick two-stage scrotal inlay procedure. Basically, we give incision through the bulbar mucosal, bulbar membranous structure via perineal incision. Transposition of posterior scrotum over the urethrotomy to determine the appropriate level of secondary scrotal incision. Completion of the first stage repair the secondary scrotal incision suture to the urethral edges, marking of the incision for the second stage. After the elevation of the skin and subcutaneous tissue border, closure of the new urethra is performed, followed by closure of the periurethral tissue. This is the diagram. This is the blended two-stage urethroplasty with a posteriorly based scrotal inlay flap. In this inverted V-shape incision is given over the scrotal flap up to the apex of prostate. The scrotal flap is developed, exposing the perineum area and open urethral margin for proximal structure. The first stage procedure is complete by suturing the posterior scrotal flap. This is the second stage. This is the Johnson original stage urethral reconstruction. This most common pain urethral stage is commonly performed.
Johnson's first stage and two-stage urethroplasty should be done in the infected stricture, complex stricture, panurethral stricture. If the panurethral stricture presented with the pussy discharge and multiple water can perineum, then we have to do the Johnson's first stage. Otherwise, we can do double phase BMG urethroplasty in non-infected stricture. So this is old classification that we have to do the Johnson's first stage in panurethral stricture. Panurethral stricture, if they are infected, there is a pus and pussy discharge and multiple fistula in the perineum, then we have to do the Johnson's. Otherwise, if simple, there is a panurethral stricture which are non-infective, there is no fistula, there is no complication, then we can do double phase BMG urethroplasty.
Thank you. Urethroplasty complication. urine leak 0 to 25%, fistula 3 to 5%, recurrence 20%, but 70% treated with DVIU. ED 20 to 27%, post-wide dribbling, injury to the bulbospongiosum muscle fibers 8 to 21%, urethral circulation less with the dorsal, graft loss, anastomotic breakdown, penile skin necrosis, and penile chordae or deformity. Faciocutaneous urethroplasty complication, recurrent stricture 5 to 60%. Recurrent stricture can be treated with dilatation, DVIU, or repeated urethroplasty, including an anastomotic urethroplasty for a short segment primary buccal mucosal graft if adequately graft bed is present, or two-stage Johnson urethroplasty. Urethral diverticulum, post-wide dribbling, ejaculatory dysfunction, urinary extravasation, urethocutaneous fistula, penile skin necrosis, erectile dysfunction, diminished or penile sensations. Interior anastomotic urethroplasty complication, acute urinary extravasation 1 to 4%, post-wide dribbling 5 to 15%, erectile dysfunction 2 to 17%, quadri less than 5%, recurrence 5 to 10%, recurrent UTI 2 to 4%. Posterior urethroplasty complication, failure 10 to 27%, ED 14 to 15%, incontinence 0 to 18%. Positioning related complication also can occur. Thank you.